So Susie's going to come and talk to us about opioids, and there are some case studies in her presentation, and so you will be asking for some participant input. Yeah. So put up your hand, and it'll turn that one on. Yep, it's on. So do ask for, so do put your hand up, and we'll come and bring you a mic if you want to say something, ask a question, give a comment, and we will be doing another role play before lunch.
So I'm going to talk about opioids today, and we're going to focus on pharmaceutical opioids just because that's been very topical, and it's also something that seems to be presenting a lot in primary care at the moment, particularly with the codeine rescheduling. I'm pretty confident everyone here is going to know what we're talking about with opioids, but obviously that does include heroin, codeine, a range of stronger pain relievers, and also methadone and buprenorphine, so all in this class. Again, at the risk of stating the obvious, we've had a pretty dramatic increase in opioid prescribing in Australia. So in particular, drugs like oxycodone are still really increasing year on year. The reason that we're worried about that is because we've also seen increasing opioid-related mortality. We've had a 50% increase in opioid-related mortality in the last 10 years. And the majority of these deaths are due to pharmaceutical opioids. So while there's been a relatively steady proportion of heroin-related deaths, and it is around 30% of the deaths, 70% of opioid-related deaths are attributed to pharmaceutical opioids. And these deaths represent both people who are using opioids in therapeutic contexts, as well as people that may be using them non-medically. In terms of treatment dependence, we've also seen a pretty good upswing in the number of people that are experiencing problems and seeking help with pharmaceutical opioids. So when we look at our pharmacotherapy statistics, so people entering methadone and buprenorphine, 1 in 3 report any pharmaceutical opioid, and 1 in 20 are reporting that codeine is the main drug of concern, which I think is a relatively high number of people entering methadone and buprenorphine treatment from a relatively what's considered weak opioid. And we've also seen significant increases in our other treatment services and counselling services, etc., with these pharmaceutical opioid related presentations. So I would expect, given this, that you're probably seeing increasing presentations in primary care as well. Also, something that I think is becoming more understood now are the problems that we're seeing with opioids among people who have chronic non-cancer pain. So, for example, I'm involved, and there's a lot of words on the slide, I can tell you the punchline. So I'm involved in a cohort study of patients who've been recruited through community pharmacies, regular patients only recruited because they're using opioids for chronic non-cancer pain. And among these, 1 in 4 meet criteria for addiction. There are a lot of different ways that addiction or opioid use disorders are defined, and it varies depending on the way that you capture it, but it seems to be around 1 in 4, 1 in 5 of these patients using these medications for pain are reporting kind of problems with things like loss of control around how much they're using it. And the other thing, just to put this in context when we're talking about the opioids as well, is we see that particularly with the higher doses, we see the greatest problems, and not only greater problems with opioid dependence, also with aberrant behaviours, but also with things like mental health problems, benzodiazepine dependence. It seems to really cluster around those people that are on the higher doses. And we also have patients themselves report more problems in terms of their own concerns about opioids. And so this isn't just us being worried about patients, but also patients experiencing problems and describing those. In terms of over-the-counter codeine dependence, again, we don't have over-the-counter codeine anymore, but we're probably likely to see in the coming weeks to months patients that are presenting where this might have been a feature in their lives. And it's difficult to get an estimate, but from the studies that I've been involved in, around 1 in 5 people who have been using over-the-counter codeine meet criteria for dependence. So it's probably much higher than we previously thought. And some of the things that identify these people as being at risk of dependence are having histories of things like chronic pain, psychological distress. Having a history of alcohol and drug problems does increase the likelihood that someone might be dependent, but we also note that the majority of people who are dependent have never had problems. So it is a group of people that might not necessarily be familiar with drug and alcohol problems or treatment services, or really be sure about where to get help. I would note that some of the things that are not associated with dependence includes differences in age, gender, employment and education. There seems to be a drug problem that affects people fairly equally. And so trying to assess somebody on appearances, whether or not they might be at risk, probably isn't going to be that helpful. And we really do need to be talking to patients to try and find out if this is something that's been a problem. We also have found from our previous research that the majority of people who meet criteria for dependence have never sought help, never spoken to their GP or done anything else about it. And it is something that's relatively hidden and probably will require a little bit of questioning. And again, we see higher proportions of females, and commonly people are employed, and both of these factors can affect people's ability to access drug and alcohol services that are often 9 to 5. So again, it might be more likely that they'll be in primary care. And the other feature that we've seen with codeine dependence is often psychosocial stresses are really driving that ongoing codeine use. This is a really busy slide, and the only reason that I put this up is just to highlight when we're talking about problems with opioids, there are lots of different ways that they're classified, which includes the DSM-4 or 5 as it is now in the ICD-10, but there are the same kinds of features that come up again that we're going to identify with problems. And these are things like people taking more than they intend to, having difficulties cutting down, craving, spending lots of time trying to get the opioids. We do have tolerance and dependence as features that are diagnostic, but that on its own doesn't mean that somebody has a drug and alcohol problem and needs to be referred to a drug and alcohol service. We obviously expect that, but when we're talking about dependence with opioids, we're talking about a lot of these other features of loss of control over use. So I guess one of the difficult things with opioids is how to initiate those conversations, and hopefully today we'll get some good practice with that. One of the things that might be a little bit different when we're talking about particularly prescribed opioids compared to, say, alcohol or methamphetamine is it's a lot grey in terms of the reasons that people are using it. They are using it for pain, but they may also have developed problems, and trying to tease that apart is sometimes a little bit less straightforward. So I guess, in terms of trying to talk about this, some really potentially obvious things, but really talking about it from the patient's perspective, and again, talking about, this is probably for most substances, the benefits they might be getting versus any disadvantages, and the potential negative aspects. And we do know that patients themselves will identify problems and concerns about the opioids that they're experiencing. And I think we're at a time in history now where we really need to be, I guess, reframing the knowledge and where opioids sit in clinical practice. And I think that a lot of the recent research that we've found has demonstrated that using these higher doses and over longer periods of time are actually associated with diminishing returns. So maybe initially in the first few months, patients get a lot of benefit from the opioids and they get good analgesia. But as the doses go up, they might be getting more side effects. They might be not getting that good analgesic effect anymore, and they're certainly at increased risk of overdose. So we know doses of more than 50 milligrams of oral morphine equivalents is kind of one cut point that seems to be associated with greater risk, and then 100 milligrams again. So I think when talking to patients about the opioids, it's a little bit about kind of saying, well, look, initially it was thought that very few people would develop dependence. Now we know that's not the case. We also, initially it was thought that these medications might be good for chronic pain, but it seems like after a period of time, they're not as effective for people, and because you get used to these doses, the dose keeps going up. So I guess trying to put into context that our knowledge has changed and that patients might not know this. Again, are people familiar with we've been talking about the 5 A's of pain, the 5 A's of, I guess, talking as ask, assess, etc. But there's also 4 A's of pain, which is very confusing. But this is a really good framework, I think, for trying to assess the role of opioids for patients with chronic pain. So these 4 A's are different, and if you do, now you've got 9 A's, I guess, by the time you go home, plus the possible 10th A of affect. So essentially, the framework here is really analgesia. Are people getting any analgesic benefit? Are the opioids still helping them with their pain? Because in some cases, they're not. Probably more importantly, and this is the way I guess the pain specialists have started to talk about, is are they getting benefit in terms of what they can do? So activities of daily living, physical functioning. Can they get out and about if they have the opioids for pain? Does that actually improve the level of functioning, or are they still sitting at home on the couch, kind of out of it, and not getting those benefits in terms of enjoying their life? adverse effects, which includes side effects, but also aberrant drug-taking behaviours, or I guess more of the addiction-related outcomes. So are there problems with loss of control that we're seeing signs of? And then affect or mood, sort of the fifth A. And one tool that, just in that first A, is really helpful. I don't know if people have seen this, but we find this a really kind of good short tool to use. It's a 3-question tool that you can use to just look at whether or not people are getting a good analgesic effect and also how they're functioning in their life. And I'm pretty sure you can access this through things like the ACI Pain Network and Health Pathways to download these sorts of tools. So I guess, again, when weighing this up with the patient and we're talking about motivational interviewing and trying to work out where a patient's at, reasons that maybe opioids aren't kind of working out well can include that the pain is still quite significant despite opioids or increasing doses of opioids, that the patient themselves doesn't feel like things are improving in their pain or function, that they're having complications that might put them at risk, that there are signs of drug seeking or aberrant behaviours or loss of control over use. And essentially, when adding all of these up, that maybe the risks for the patient outweigh the benefits, which is, I guess, always the balance with a drug. So I just wanted to think about some of the skills that we've been, and questions and ways that we've been thinking about this, and present a case and try and think about, for this particular patient, if we can identify both the things that are concerning, but also where you might be able to buy in, or if the patient is a little bit ambivalent, where we might be able to think about this. So this is John. He's got a long history of chronic lower back pain. He's prescribed OxyContin, 160 milligrams a day, so it's having 80 milligrams in the morning and night. Also with a little bit of endone, and you have become aware that he gets endone from more than one doctor recently. He's also prescribed benzodiazepines and antidepressants, and he said his pain's getting worse. And you've noticed that he's coming in for his prescriptions a little bit more often. He also, he looks a bit distressed, he has a low mood, and he mentions that he really needs the opioids and he can't imagine how he's going to manage his pain without them. So I guess just amongst your tables, just...
Do you want to do it with everyone or just in the table?
I was thinking people would talk amongst themselves, but yeah, just among your tables. I mean, to just try and list just for a couple of minutes, what you think the key concerns are here that you would be worried about, and what ways that you think that you could talk to John in terms of things in here that might be a good way to highlight for him those risks and benefits.
So in your tables, have a little chat. And I think what we might do at the end is just grab a couple of the tables just to get a bit of feedback to the group. Okay, guys, we're just going to grab a couple of tables. This table here. What were the concerns?
The main concern was patient was drug dependent, and also he was suffering from low mood, so depression along with drug dependence.
Why do you say drug dependent?
Because he was taking medication like excessive dose, so he was out of his medication. So he was here for another prescription for pain medication.
You're prescribing those medications?
Actually, I was not finished with my history. Yeah.
And over here, how do you get buy-in? Who hasn't said something yet? I'm going to come around here. How do you get buy-in?
I don't even know what buy-in is.
Weren't you guys talking about this at your table? Were you talking about going on holidays instead? I should have come up here. It would be much more interesting. Yeah, what does buy-in mean, Suze?
Yeah, so how do you get the patient to be motivated to make a change? How do you get them to buy in? You've got your concerns. How do you get them to identify their concerns, and so that you're both working in the same direction, I guess, is what buy-in. That's a phrase that I use in my life. Maybe, sorry everybody.
It must be a Newtown phrase. Maybe it's an Inner West phase. Moving on.
So moving along. I guess some of the options, if you've got a patient in primary care settings, to try and kind of work out for John, for example, what we could do. I guess there's a range of options that start with maybe a medication review, try and work out exactly what he is taking and where from. maybe putting in a little bit of structure, something like stage supply. So, you know, maybe he doesn't pick up his medication once every 2 weeks or once every month, but he picks it up every 2 days from the pharmacy. So he's not getting such large amounts at home. You know, particularly for this patient that's also on benzodiazepines and antidepressants and has a low mood and a number of risk factors, maybe you don't want him to have a huge amount of oxycodone at home. So that could be something with a community pharmacy where you can get a little bit of structure. For some patients, that can be enough. For other patients, when that fails, that can be a good decision point to be, well, we tried that. It seemed like that didn't work. We probably need to go to the next step. There's always the option of referring either to a pain team or to an addiction team when you start to get these patients where, you know, you feel a little bit uncomfortable going on your own, and it can be helpful to get that second opinion around whether or not this is an appropriate and safe way to continue. For someone that's really met these criteria for opioid dependence, and you're no longer talking about pain management, but you're talking really about primarily an addiction-related issue, we have pharmacotherapies for that, which include either buprenorphine taper, so reducing people off in an in or outpatient setting, or these maintenance treatments that have a really good evidence base, so methadone, buprenorphine, naloxone. Naltrexone is available. It's going to be a select population that might be appropriate for, but occasionally that's something that's on the menu as well. Naltrexone is an opioid antagonist, so people are probably familiar for its use in alcohol dependence, but it is occasionally used for opioid dependence. And also just something to consider, and this is always something when I see a John, and you know, when we see a John that might come into, you know, drug and alcohol treatment service, for example, he's got a lot of red flags for being at overdose risk. So high, very high dose, 160 milligrams of oxycodone, plus a bunch of endone, probably on, you know, 200-300 milligrams of morphine equivalents at least, plus a benzo, plus some antidepressants.
I think one of the main concerns
Hang on.
is the problem is, I think, as general practitioners, you really have to, I mean, Gilbert will agree, benzos. Most of the coroner report, most of the deaths that have occurred, and you'll find, and I've lost over the years, many people, is benzos and opiates.
Yeah.
Don't go together.
Yeah, so I think that when you're identifying these patients, sometimes it's difficult to get around to fixing the whole, you can't fix the whole thing in one day. You're probably going to have a conversation. But one conversation that you can have is around, look, you know, these medications can be dangerous. You know, there is a risk of overdose. There is a medication that you can keep in your home. Is there someone, do you have someone that you live with that we could maybe get them to come in? You could talk about it. It might sound extreme, but this is something that is a patient-centered conversation, and it could save a life. We do this a lot with people who are coming into treatment for opioid dependence services and other harm reduction services that focus on meeting the needs of people who use or inject drugs. This is a really common thing that we try and offer everyone, but it can have a role in these high-risk patients, and it can be a patient-centered way of kind of bringing about the fact that you're concerned that there is a risk. I'm just going to leave that there. In terms of opioid agonist treatment, when we're talking about treatment options for patients today, this is one option. It's not the only option, but for patients where, again, the opioids have become the primary problem, pain isn't the primary problem anymore, and there is kind of risks about escalating use. These are evidence-based treatments, very strongly evidence-based treatments that are effective for people who are opioid dependent. It's not going to be appropriate for everyone, but particularly appropriate where people really do meet those criteria for opioid dependence, or I guess the more severe end of the opioid use disorder spectrum, where you've tried those other strategies. You've tried stage supply and supervised dosing. You've tried to taper people off and it hasn't worked. Maybe that's part of the pathway of getting to these options. And particularly where there is a really significant risk of overdose or relapse. And probably most importantly, where the patient is willing to consider it. And that can be, again, a number of times of bringing up this idea. Maybe it's referring to your local services or getting some assistance from drug and alcohol teams. But it can be a bit of a journey to kind of introduce this as an idea for a patient that's lost control. John may not be the person that you send straight to the drug and alcohol clinic. There's probably quite a journey in kind of talking to him about where the opioids are happening in his life, whether he's getting those benefits, whether or not the risks are outweighing the benefits, and trying a couple of things. But ultimately, if the use keeps going up, you're getting on higher doses, maybe there's been an overdose incident, you know, that might be the case where you're starting to think about these treatments. The other thing that I found, particularly with pharmaceutical opioids, that I thought would be just useful to mention is opioid withdrawal symptoms. I don't know how familiar everyone here is with opioid withdrawal symptoms, but certainly one of the things with over-the-counter codeine is that patients themselves don't often recognise opioid withdrawal. And when they're taking medications really frequently and self-medicating and thinking that what they're doing is taking the medication for pain, but actually what they're doing is taking the medication to stop the onset of opioid withdrawal symptoms. And that's, again, something where it's really educating patients to understand what these symptoms are and that these emerging symptoms might not be pain, that they might be opioid withdrawal, can also be helpful in putting the pieces together for a patient. So things like you know, the runny nose, the tears, the goosebumps, piloerection, so nausea, vomiting, diarrhea, lots of gastrointestinal symptoms, tachycardia, hypertension, restlessness, muscle aches and cramps and things, insomnia and craving. If you work with people who have used heroin, for example, they're usually pretty familiar with these symptoms and have experienced this cycle of opioid withdrawal commonly. You don't need to do often as much education, but what I found with people who are dependent on pharmaceutical opioids and pain medications and codeine, over-the-counter codeine as well, is that this is very unfamiliar and you do need a lot of education to kind of help this make sense for a patient. In terms of opioid agonist treatment, again, I've done a lot of work looking at the evidence for using these treatments that we know work incredibly well for illicit opioid dependence, or traditionally all of the research happened with illicit opioid dependence. The work that I've done that I can summarise in one sort of punchline here is that they work just as well, if not better, for pharmaceutical opioid dependence. Methadone and buprenorphine tend to be equally effective, although there might be some safety reasons why you would prefer buprenorphine naloxone. And that detoxification tends to be less effective, so many people will relapse. But we do see very good treatment outcomes, and if you are concerned about patients, reaching out to drug and alcohol teams and considering these treatment options is certainly a viable treatment plan. Rather than talking a lot about the evidence today, I do have a summary that you can download online, and I'm sure that this can be shared with people that goes through all of those things. So we've just got one more case, Janine. This is maybe a little bit timely. So Janine presents requesting a script for codeine. So she's been using it for headaches and back pain, and she's been using it for many years in that way. I want you to start, just again, have a couple of minutes on your table to think about what questions you might ask and how would you assess whether or not it's appropriate to provide this codeine script that she's requesting. What you might consider prescribing. So again, breaking off for a couple of minutes on the table to look at these questions and really focusing on what are the kinds of questions that you would ask Janine to try and work out where to go from here. Oh, how old Janine? Janine's 37. She's 37. 37. And she's a teacher.
So just a couple of minutes once again at your table, thinking through those questions, and we've got our table facilitators just to kind of help people keep on track. Is everybody?
I can't remember how old Janine is. She might be a little bit older. Yeah. Have you had many people presenting, asking for, yeah. So getting a few patients. What sort of things were you asking, to determine if you were going to prescribe? Yep. Yep. Does anyone want to volunteer a couple of their first questions that they would ask?
First, to assess how much of codeine she's taking. So you've got to calculate,
Yeah.
Because if it's over the counter, it's 8 milligrams or 12 milligrams
Yeah.
in compared to Panadine 4. So actually, you really have to assess how much of codeine she's taking.
Yeah. Any other top questions? I can go through my little list. Yeah, amount and frequency.
Sorry, Susie.
Yep.
And of course, we understand that codeine, after long-term use, it loses its edge.
Yeah.
It may not be doing much for the patient, and the patient needs to be educated regarding the side effects of codeine, and it's not doing much, need for a change.
Yeah, yeah. So it's sort of, automatically continuing the codeine might not necessarily be in the patient's best interests. We've got a little bit more about Janine. So this is our initial assessment, but I guess trying to work out how much is she using, how long she's been using it. I just threw this question in because this is something that came out of our research as a really clear marker with over-the-counter codeine. If people ever report taking more than 2 tablets at a time, so escalating beyond that recommended dose, that's a really clear sign that probably there are some issues going on. So, and it's probably a less confronting way to sort of ask someone about it. Maybe, do you ever have to take more than 2 tablets to relieve your pain? But often, people might not disclose that automatically, and this might be a good way to ask about that. And if they say yes, can you tell me a little bit more about that? Also, obviously, assessing these symptoms. What are the symptoms of sort of headache and back pain? Has she tried anything else? And what happens when she doesn't use codeine, I think, is another really good question, talking about those opioid withdrawal symptoms before. So a little bit more about Janine. So she's been using for about 3 years when she injured her back. She also increased her use at around the same time that she was experiencing some bullying issues at work. So she's actually taking 45 tablets of Panadeine a day. So really asking about those use patterns can be helpful. And she's been doing that for about 12 months. So maybe around 360 milligrams of codeine. And she did try and stop when she heard about codeine not being available. And she didn't feel very well, and she wasn't able to stop, and she's kept going. So I guess kind of thinking through this case for a couple more minutes. Do we have time? Yep. So, what would you advise in terms of her use? How could you assist, and what could you arrange? So again, just a couple of minutes talking about a couple of specific things that you would think about for Janine. It's interesting with healthcare professionals, with people who've been taking long-term paracetamol. If they've escalated to go slowly, there seems to be leave tomorrow. Will it come? Okay. Put my mic's on.
Okay, guys, we're just going to come back. Susie's got a few more minutes. Just quickly do her. Yeah. Okay, so just moving on.
Okay, so now we're going to move on and just talk about Tamara, slightly different presentation again. But we've just got a couple of minutes before we move into our final role plays. So Tamara is another interesting case. So she's been prescribed fentanyl patches with a diagnosis of fibromyalgia. She was on the lower strength patches and that's gone up. And she says they're not working as well, and she started changing them more often to try and see if that worked better. Maybe they're just running out. And she feels like her pain's getting worse. And she's also got a younger child with a learning disability, and she's under some financial pressure. So complicated presentation here. So again, just a couple of minutes to talk about, in Tara's presentation, are there any signs there that she's opioid dependent, and what are the things that you'd be worried about? And what do you think is the first thing, or the first things that you would do to respond? I'll put her back up.
Yeah, so in your groups, once again, your concerns. Is she opioid dependent? What was the third one? Sorry. Opioid dependent concerns, and how do you respond?
We could probably actually just do this as a big group.
Yeah,
actually.
okay. So
hands up who thinks she's opioid dependent. So we got a number of people that think she's opioid dependent. I guess when I'm thinking about a case like this with Tamara, does seem like she's using larger amounts and not necessarily longer than intended. She's pretty early days, Tamara. Tolerance, her dose is going up, maybe. Some of these other things that really might lead you to conclude or diagnose opioid dependence, probably maybe not there yet, or we don't know enough. But certainly there are concerns. So I guess I would be on the side of probably not, we don't have evidence that she's necessarily opioid dependent yet. But are we worried about Tamara? I think we're certainly worried about Tamara. So I guess some of the things that I would be concerned about particularly is her pain. She feels like her pain's worse. She's going up on a dose of opioids, but she's not getting better. So I guess usually if we increase the dose of a medication and a patient gets worse, we don't think that that's the best medication for the patient. So maybe that's a sign there. And also she seems like she's under a lot of stress. Yeah.
The fentanyl normally we use for the short acting, and she's using patches fentanyl and diagnosed recently with the fibromyalgia. I think it's better we can change the treatment to duloxetine, 30 milligram low dose, because it's prevent like pain management as well as she's depressed. Therefore, we can explain this way, and we have to change to duloxetine, 30 milligram, and while GP can increase 60 to up to 90 milligram. Is that way to do? Or?
So what was that? I missed the drug name that you said there. Duloxetine. Yeah, so I think, maybe this is a patient where opioids just aren't a great option. And fentanyl for fibromyalgia, maybe, this is a bit concerning. But yeah, I just think maybe we haven't quite got it right. And I think thinking about other strategies and non-drug strategies for sure. So I guess this is maybe things we could consider. She has poorly managed pain. She's got an escalating dose, and she's got psychosocial stresses. Kinds of things we might be thinking about. Referral, maybe to get an assessment around the pain management. Maybe a mental health care plan, trying to get her some support. And certainly, non-opioid pain is probably more appropriate. And I guess getting back to this key question is, are the opioids resulting in improved pain management and functioning? And I think most of you will probably agree for her, the answer is no. Do we have time for this? Okay, so I guess one of the key concerns is, what do we do if Tamara gets angry? Tamara's like, I just want my script. I need this. Can you give it to me now? And she's really kind of escalating. And trying to get the discussion to get back into a place where you can help Tamara can be difficult from there. So I just want to do a really quick 1-minute exercise where, again, in pairs, I want one person to be Tamara and to be angry and to be upset and to want those patches. And your job for the 1 minute person is to try and maintain that anger. And then I want for the person who's being the prescriber to just agree with Tamara. To whatever she says, try and find a point of agreement. And try and, whatever it is that she's saying, I want you to be saying yes and finding a place that you can have her be heard and finding, and really hear those concerns. And just see how that feels for both of you. So can everybody just agree really quickly who's going to be the patient, who's going to be the doctor?
So, Suze, it's not that you're agreeing to prescribe the medication.
No,
you're actually saying
prescribe.
You're saying no to the medication.
Yeah, sorry, just to clarify, you're not agreeing to do what she wants, but you're agreeing with her concerns. So you're hearing her. So should we do a quick example? Yeah.
We just want to do a quick example just to show you what we're wanting you to do. So I'm going to be, guys, just stop. It's way too civilised and kind, the stuff that's going on here. So what we're going to do is I'm going to be the angry patient, and Suze is going to be the doctor who's saying, actually, no, I'm not going to give you those, but is actually...
But I'm starting with yes.
Yeah.
Rather than starting with no.
So, Dr. Susie, I just want my medications.
I understand that you really want
No,
your
but I really need them.
You
I've got so much going on in my life.
I hear you've got a lot going
Look,
on in your life.
I came in here for my medications. I've got to go and pick up my daughter. I'm really in pain. This is really not okay.
I can see this
What am I supposed to do?
Look, but we need to make a plan.
I'm not able to sleep.
I know, it's very difficult. I hear what you're saying, and let's see if we can make a plan for you. I understand that this is a really difficult situation.
It's really hard to stay angry at her.
So just have a go. You're not saying yes to the opioids, but you're saying yes and hearing and agreeing and nodding, and try and stay angry under those circumstances. Go.
It's not like noise.
No, you...
Come on, guys. We want a bit of anger. Come on, patients, get a bit angry.
Yep.
Remember all those patients that are giving you a hard time, and just, come on, we want the sound to go up. I need my medications. Why aren't you giving me my medications? What sort of doctor are you?
Who's angry here? I hear no anger. You're angry? How did it feel having someone agree with you when you're angry?
Come on, you gotta get angry.
Stay angry.
Okay, guys, we're going to move on. You guys are way too sweet. There wasn't enough method acting getting into the patient's anger there. But moving on, guys, can I get you to come back to Susie now?
So I've just got a couple of resource
Guys?
slides. These are in your booklets, but if you're seeking advice for patients, obviously there's ADDIS. And if you're seeking advice, particularly with these really concerning, maybe high-risk opioid patients, you can call DASIS any time of the day or night, 24 hours a day. I mean, probably better not to call at 3 a.m. if you don't have to. But you never have to kind of make these decisions about patients on your own. There is always someone to ask for help. So just in terms of that exercise, how did people feel when they were being heard and being agreed with? Was it hard to stay angry? Yeah, I mean, it needs to come from obviously an honest place and a place of respect. But I think if you can first, even if it has to be a no, not to lead with a no, not to start with, look, there's no way I can give you that medication today, but just start with even like when the person's getting upset, really trying to hear what it is that's making them upset, what the concerns are, which might not even be related to the medication ultimately, before kind of saying that, look, I can't prescribe this. It just tends to end in a better kind of discussion, and it can be really scary. I've spent lots of time doing methadone and buprenorphine dosing where sometimes for patient safety it's not possible to provide a dose, and that can be a really confronting and upsetting kind of discussion to have. But I think if you can really try and have people be heard and try and know what it is that's driving their concern, it's going to be better in the long term.
I just wanted to add in here, so we have DASIS, which is fantastic. When you ring it up as a GP, you get to talk to an intake worker who quite often can give you the information you need, or they will get a drug and alcohol physician to call you back, someone like Gilbert. Wouldn't it be fantastic to have Gilbert on the end of a line? The other thing is that in Western Sydney and South Western Sydney, there are the new projects. So there's Michael and Jenny and who else? Nikki? Is it? Yeah, sorry.
Yeah, Robert and Tal and Nada at the back are just, the person's not started yet, but there will be a GP liaison nurse very soon to help, and also specialist backup.
Fantastic. So watch this space in Western Sydney. Beautiful. So I'm sorry, I am aware of the time. We do need to move on to the role play. Abby, if you could hand out the role play to the table facilitators, and if you were a patient last time, be the doctor this time. If you were the doctor last time, be the patient this time. Okay? And have a go. I know it's easy not to, and it's just before lunch and it's been a bit of a long morning,
All right,
but
so
really
who's
have a
gonna
go.
be
Dive
the
in and have a go.
patients?
Pulling this to a close with this lovely case study whose name I've forgotten. Who was it? Sarah. Okay, guys, thank you. I just want to get 2 comments from a table that hasn't given a comment. Maybe this table here. So, Sarah, a comment from you guys around what issues with that role play, or what went well, what didn't go well? Grab the microphone. Come on, somebody be brave.
So I was the patient at this role player, and doctor, he just tried to explore the reason for my visit, and I was insisting for prescription of oxycodone. So he displayed good communication skills and showed me like he wanted to explore more into the reason why I need this medication.
And he did it well.
Yes.
I'm going to come over this table. No, I've already harassed you once, haven't I? Who haven't I harassed yet? Which table? Maybe down here. Okay. So feedback on the role play. Who wants to?
Probably just to comment that, you do get caught a little bit between genuine pain and wanting to manage the pain, as opposed to the withdrawals and the dependency. Because in our situation, I was the patient, but I did have genuine pain, and it was being investigated, and I was doing all the right things, you know, no significant history of addiction type problems, but obviously I'm developing one, and I think, you know, the doctor's role is to try to, you know, still maintain some degree of, you know, treatment for the problem, but obviously balancing it without dependence.
I think that's a really important thing that you raise, that this is not a genuine good patient, bad patient. This is, opioids are a medicine that we have used as a species for more than 4,000 years. We have receptors, we have opioid receptors in our bodies. We get side effects from them, constipation, and sedation, and tolerance and withdrawal symptoms if we take too much. You know, not everybody gets constipation. Not everybody gets tolerance and withdrawal and dependence. But it can happen, and as Susie said in her talk, it's probably somewhere between 1 in 5 and 1 in 4. And so really, yes, our patients do have pain, but we want to make sure that the treatment that we give them is effective and safe. It's not about them being a bad person or being a doctor shopper. It's actually about working together with them to find solutions. Now, I'm going to finish up. There's just one more thing that I wanted to say before we finish before lunch, and that's about the opioid substitution treatment or opioid agonist treatment method, medication-assisted treatment of opioid dependence. What you would know is methadone treatment or Suboxone or buprenorphine treatment. Very shortly in New South Wales, the guidelines will change. They will come out very, very shortly. And what is going to happen with those is there's going to be a change in what all of us can actually do without any additional training. At the moment, any one GP can take on up to 5 people that are already stable in treatment with either methadone or buprenorphine naloxone. What will happen with the new changes is that you will be able to commence, to start treatment with Suboxone for up to 20 people. So at any one time, you can be treating 20 people, starting them up on treatment with Suboxone. In addition to that, if you wish, you can take on another 10 people who are already stabilised in treatment, either on methadone or Suboxone. Now, I don't think there's going to be people rushing to do this, but it's just important that you know that that change is happening. And given that codeine has now come off the market and there's this increasing understanding and knowledge around the issues that people can have in terms of their opioid use, you're going to find that there will be a group of people who will benefit from this really excellent, safe, evidence-based treatment. So, and you're really lucky at the same time as these changes are happening, you've got Jenny, you've got Michael, you've got Robert, you've got the people that can actually support you to do this.